Hi, a very good evening. So today's quick revision class will deal with few important concepts from endodontics along with image-based discussion, including case-based questions, right? I hope you guys are all ready. So please confirm the audio and video streaming. We'll go ahead with our session right away. Yeah, it's almost 8:35. So before we start our endodontics quick revision class, I hope you found out the answer for yesterday's case-based question. So we'll start with that and then we'll proceed accordingly. So before that, a very good evening each and every one of you. I know IPL is going on, the final is going on, and I'm still glad you guys are able to join live. So let's start with our presentation right away. Okay, thank you. So first and foremost, I missed this slide yesterday. So I wanted to present this first. So this is near my hometown, Vijayawada. You can see plenty of greenery. It's actually a drone view, a sunset while I was coming home from college. Very recently, I shot this very recently. So greenery always is special. Nature, Mother Nature is always special, always refreshing, isn't it? So let's start with our quick revision class, endodontics. But before that, as I said, we'll start with the previous session's case-based question. So patient returns to your clinic 24 hours after you cemented a gold crown in relation to 3-6. Patient complains of sharp electrical sensation in both upper lower jaws on left side. Patient has amalgam restoration in relation to 2-6. So this sharp electrical sensation which the patient is feeling could be due to, as most of you rightly answered yesterday, it is galvanic shock. Now let's review some literature in regard to this. So as you can see in this illustration given in Phillips, so two dissimilar metals, when they come in contact or even when they are not in contact, two dissimilar metals, they have different electrode potentials, and also saliva or tissue fluids have potential to act as electrolytes. So it's nothing but an electrochemical cell that's being formed intraorally. So galvanic shock is brief but sharp electrical sensation one can receive when two dissimilar metals come into contact in the mouth. And before I review relevant literature, let me ask you this question. I think it's already there. I actually wanted to ask you this question. Let me just go back. So when you have gold restoration on one tooth and opposing tooth, you have amalgam restoration. Which one acts as anode? Which one acts as cathode? So try answering the same, and then I'll present that second illustration, which has the answer for this particular question. So an amalgam restoration is placed on occlusal surface of lower tooth directly opposing a gold inlay and an upper tooth. An example. So because both restorations are wet with saliva, an electric circuit exists with a difference in potential between the dissimilar restorations. And when the two fillings are brought into contact, there is sudden short circuiting through the two alloys. This results in sharp pain because pulp has this capacity to carry pain sensations. And such post-operative pains usually occur immediately after insertion of a new restoration, and generally it gradually subsides and disappears in few days. Clinical relevance, this is very, very important, right? So you need not do anything. You need not intervene as such. So among these two restorations, which one acts as an anode, which one acts as a cathode? Remember, we have an EMF, electromotive force. We have electromotive series, where you have more positive elements or metals on top and then more negative at the bottom, and hydrogen is almost at the center, exactly at the center. So when two metals are chosen from that particular series, the one which is more positive acts as a cathode, the one which is comparatively negative acts as anode. So in this case, as you can see, amalgam, silver amalgam acts as an anode, right? Where oxidation happens, anox, right? We have a mnemonic, anox. Anode oxidation happens, loss of ions, right? So gold acts as a cathode, right? A reduction takes place, gain of electrons. Very simple. So well answered. And I have an additional point for each and every one of you. Please make a note. It's even given in Phillips. So in fact, even though we're discussing conservative, it's a combination of 2 or 3 specialties, isn't it? So the amount of electricity involved in galvanic shock can range from 0.5 to 1 microamperes. Please make a note of this. And the potential difference is around 500 millivolts. Okay, yeah. So as you guys rightly answered, yeah, saliva acts as an electrolyte in this particular context. Very good. Now let's move on to our first question in Endodontics quick revision class. So try answering this. The requirements of an ideal pulp capping agent was given by Engel and Cohen, Herman, Cohen and Kuhn, Grossman. So which one do you think is right answer? You might be wondering why I've asked you the name of dentists or scientists, but very recently, in recent times exam, we had a question where there was the names of scientists. So let's not overlook into that. The requirements of an ideal pulp capping agent was given by Engel and Cohen, Herman, Cohen and Kuhn, and Grossman. So which one do you think is a right answer? Very good, Monica. Yeah. 0.5 to 1 microamperes. Okay, so let me review some literature and then let me get back to this answer. So as you can see in this illustration, it's a illustration which depicts presence of the reddish one, which you can see, that's nothing but a pulp capping agent, right? So you could consider that as pulp capping agent. So according to Cohen and Kuhn, as you rightly mentioned, as most of you rightly mentioned, Cohen and Kuhn, right? The requirements of an ideal pulp capping agent include, number one, it should maintain pulp vitality. That's the reason why you're capping the pulp. It should stimulate reparative dentin formation, isn't it? So that would be an ideal case scenario, stimulation of reparative dentin formation, pulp protection. And then it should be either bactericidal or bacteriostatic in nature and should be able to provide bacterial seal. It should adhere well to both dentin and overlying restorative material for retentive aspect. And it should be able to resist forces, resistance aspect. And it should be sterile. It should be preferably radiopaque for our convenience so that we can view it under a radiograph, right? So these are some of the ideal requirements of pulp capping agent as given by Cohen and Kuhn. So option C is a right answer, okay? If you're right, fantastic. If you're wrong, that's absolutely fine. Now is an opportunity for you to, adjust, readjust the wiring, the knowledge wiring in your brain, and then move ahead with confidence, right? Now let's move on to our next question. SCAP stem cells are found at. I'm not going to expand what SCAP means because if I expand it, the answer is quite obvious. So SCAP stem cells are found at option A, periodontal ligament, option B, pulpal cells, option C, bone marrow, option D, apical papilla. So which one do you think is right answer? So in the meantime, I want you guys, to just go through this following literature. So stem cells, according to Diogenes et al., regenerative endodontic procedures are stem cell-based therapies. Stem cells are undifferentiated cells which can be either pluripotent or they can be multipotent in nature that are capable of differentiating into various specialized cell types. So these cells are located in specialized regions within the tissues termed stem cell niches. And there are different types of stem cells. Stem cells of apical papilla, SCAP, the one based on which we had this question, dental pulp stem cells, DPSCs, inflamed periapical progenitor cells, and then periodontal ligament stem cells, bone marrow stem cells from human exfoliated deciduous teeth shed, tooth germ progenitor cells, dental follicle stem cells, salivary gland stem cells. They've given a list with 9 types of stem cells, of which, according to Hargreaves, the first 5 stem cells are the most commonly employed stem cells in regenerative endodontics. That is, stem cells of apical papilla, dental pulp stem cells, inflamed periapical progenitor cells, periodontal ligament stem cells, and bone marrow stem cells. Okay, so these cells have the capability of differentiating into odontoblastic-like facilitating. They have the potential because they're either pluripotent or multipotent. They can differentiate into odontoblastic-like cells, facilitating progressive repopulation of the radicular pulp space, promoting organized tissue repair, angiogenesis, reinnervation. We're just trying to achieve what's natural, trying to achieve the blood supply, trying to achieve the nerve supply, trying to achieve dentin formation, right? So now you can see the illustration. I'm going to show you the illustration, but before that, as almost every one of you rightly answered, stem cells of apical papilla, these are found at apical papilla. Option D is right answer. Fantastic. So look into this illustration. So schematic representation of potential sources of postnatal stem cells in oral environment. So different categories which we have just gone through. So cell types include tooth germ progenitor cells, dental follicle stem cells, salivary gland stem cells of apical papilla, and dental pulp stem cells from human exfoliated deciduous teeth that is shed, periodontal ligament stem cells, inflamed periapical progenitor cells, bone marrow stem cells, etc. Okay. So look into these illustrations and try to get familiarized with the names and their corresponding locations. Consider this very, very important. Regenerative endodontics as such. Now, let's move on to our next question. Yeah. So third question, endodontic lesions should be treated before management of periodontal lesions because of the following reasons except. Option A, endodontic treatment is highly predictable. Option B, periodontal component cannot resolve till the endodontic lesion is present. Option C, progress of periodontitis is most likely fast. Option D, none of the above. So which one do you think is the right answer? Endodontic lesions should be treated before management of periodontal lesions for the following reasons except. So which one do you think is the exception? So yeah, I'll get back to these images a bit later. So try answering this. I know it's a challenging question. In the meantime, I'll review some literature for your convenience. So endodontic, see, dental, Dhiva says D question mark. See, you don't have a scope to put a question mark in exam. You have to choose your option directly. I'm just kidding, right? Okay, so endodontic lesions should be treated before the management of periodontal lesions for the following reasons. Why? First one, endodontic treatment is highly predictable. Second, periodontal component cannot resolve till the endodontic lesion is present. So you need to address that first. And progress of periodontitis is slow with the exception of acute disease, right? So therefore, prompt management of pulpal lesions is primary concern. So in general, if you observe in any population, the progression of periodontitis is slow. However, there are some exceptions, but in general, it is slow. So based on the available literature, option C can be considered as a more appropriate answer. I see very few of you choosing option C. See, periodontitis is usually slow progressing, except for acute diseases, right? So for any generalized things, we have exceptions. We need not worry about the exceptions. So among the given options, option C is comparatively appropriate answer. Okay, I hope it's clear. Now, I mean, if you have any queries or need any further clarification, you can always get back to me via doubt clarification form. Now, I have some image. I wanted to have this image-based discussion. We can incorporate perio in this particular slide along with endo. So you can see clockwise, starting from 10 o'clock. When I say 10 o'clock, I'm sure you can understand, right? So 10 o'clock, that is top left. Start from there and then move on to 12 o'clock, 1 o'clock, 5 o'clock, and 7 o'clock. And also you can see corresponding green arrows. So total 5 images, try identifying what they are. I'll give you the options. Primary endo, primary endo with secondary perio, primary perio with secondary endo, right? A mix of all this. And then concomitant lesions, right? So based on this, try identifying what each of this radiographic image represents, whether it is primary endo or primary perio or primary endo with secondary perio or primary perio with secondary endo. I know it's very confusing, but just remember, we're talking about only 2 components, endodontic component and periodontal component. Which comes first, right? That's it. Yeah, you can start from 10 o'clock, as I said, 10 o'clock, 12 o'clock, or you can name it as A, B, C, D, E. I should have named it in alphabets for your convenience, but anyways. A, B, C, D, E, 10 o'clock, 12 o'clock, 1 o'clock, 5 o'clock, and 7 o'clock. Identify those lesions. In the meantime, I'll review some literature for your convenience. So first and foremost, in case of primary endodontic lesions, you can see there can be pain and tenderness to palpation and percussion, exclusive endodontic component. I mean, if you observe the 10 o'clock image, that is A, you can see proximal caries almost involving the pulp space. So it's obvious that it is primary endodontic lesion. Do you see any periapical changes? Do you see any bone loss? Not as such. So this is a clear-cut case of primary endodontic lesion. And then 12 o'clock, you can see a primary endodontic lesion with secondary periodontal involvement. So this I'm saying because you can clearly see that root canal treatment has already been done in 12 o'clock, and then you can also see angular bone loss. I mean, you can see horizontal bone loss, isn't it? So primary endo with secondary perio, right? And then 1 o'clock, if you come to 1 o'clock, it is primary perio. As you can clearly see, there is no decay, just a restoration occlusally, but you can see angular bone loss. It could involve furcation, the lateral canals and all, right? So this is a clear-cut case of primary periodontal lesion. I hope, I haven't checked it, but I hope the vitality of the tooth is plus or positive. So it's a clear-cut case of primary periodontal lesion. I'll come to the characteristics for your convenience. And then if you move on to 5 o'clock, so 5 o'clock, it's a clear-cut case of primary perio with secondary endo. You can see no caries whatsoever, no fractures in relation to tooth. So the endodontic component seems to be not involved initially, but because of periodontal involvement, because of greater bone loss, you can see the bone loss extending almost to the apical third of these teeth. So primary perio with secondary endo. And then finally moving on to 7 o'clock. It's a concomitant lesion. You can see proximal caries, right? And also you can see a bone loss. And very carefully, if you observe this 7 o'clock image, proximal caries, involvement of pulp leading to periapical lesion. So there is endodontic involvement. And then without any relation, there seems to be horizontal bone loss. So both these endo and periodontal components are independent of each other. We call them as concomitant lesions. Okay, I hope it's clear. So endo-periodontal lesions, their identification, diagnosis part, clinical features, treatment is very, very important. Consider this topic very, very important, right? So if you need any further, yeah, of course, you'll get clinical reference or you'll get clinical information without any doubt. So in this, based on radiographic findings, we're trying to give the diagnosis, but always remember radiographs only supplement clinical findings. So whenever you get these kind of patients, you'll get clinically relevant points as well. For example, they might say a particular tooth 3-6 has, there is pain or tenderness on palpation. And also when sinus tract is present, if you trace it, it is pointing towards periapical area, which means it is primary endodontic lesion, right? So you'll have clinical clues as well. You'll definitely have clinical clues as well. There is no doubt in it. Okay. Yeah. I know we discussed so many relevant points in this one particular slide. Don't worry. Take some time and then go through each of these images carefully. Why I said whether it's primary endo, primary peri, or combined lesions or concomitant lesions, it's very obvious. Just look for the involvement of these components, either endodontic component or periodontal component. Endodontic component, how do you say it's involved? When there is caries, when there is pulp involvement, when there is periapical lesion, when there is sinus tracing towards periapex. When do you say it's periodontal involved? When there is bone loss, when there is caliculus, when there is, gingival, clinically, gingival inflammation and all. So we have certain parameters which give us a clue that this could be a periodontal case. Also, we have some parameters which will give us a clue that this is most probably an endodontic case. Okay, I hope it's clear. Yeah. Now let's move on to our next question. Yeah, by the way, I hope you got the answer for this particular question, right? So fourth question. Yeah. Which of the following is false regarding root canal disinfectant lasers? Option A, NEET and Argon lasers can be used for root canal disinfectant lasers. Option B, laser irradiates all dimensions of canal system completely. Option C, it is potentially dangerous around the apices of teeth close to mental mandibular foramen. Option D, effective method to kill microorganisms. So which one do you think is false or the odd one out? So try answering this question. In the meantime, we have a lag of 20 seconds. In the meantime, let me review some literature related to lasers. So first and foremost, laser light amplification for stimulated emission of radiation. It's a very interesting concept. So disinfection of root canals. You can refer page number 527 cross one if you're interested. So the ability of bacterial pathogens to persist after shaping and cleaning is one of the main reasons for endodontic failure. This is attributed to the complex nature of root canal system, presence of smear layer, which we had a debate session, one of our very first debate classes, and fact that large areas, that is interestingly and surprisingly, over 35% of canal surface area remains unchanged even after thorough instrumentation, such as the complexity of root canal system. So obviously you need some methods, means and methods to disinfect the root canal, isn't it? Studies have shown that carbon dioxide Nd:YAG lasers in root canals are very useful and found evidence of dentinal tubule disinfection. The laser is delivered into the root canal system with the help of thin fiber optics around diameter of 200 microns, as in case of Nd:YAG, erbium, argon diode lasers. Godis et al., one of the scientists, have concluded that there are certain limitations associated with the use of lasers. The laser beam that is emitted from the tip of fiber optic is directed, as you can see in this illustration. The laser beam that's emitted from the tip of fiber optic is directed vertically downwards into the root canal and not laterally into the dentinal tubules. This is further compromised by inherent curvature present in root canals. Thus, it is not possible to laser to irradiate all the dimensions of canal system completely, right? But as they say, something is always better than nothing. Studies have clearly shown that most of the lasers or laser irradiation is an effective method to kill microorganisms, and it can act not as a replacement, but as an adjunct to traditional means of shaping and cleaning. Another important point which I wanted to highlight is the other concern raised with the use of lasers in endodontics is inadvertent transmission of laser into periradicular region while irradiating the apical third of root canal system. This is potentially dangerous in the areas around the apices of teeth close to mental mandibular foramen, right? So just make a note of that point, which is already there in the form of an option, option C, right? So among the given options, so which one did you choose? I see a variety of options being chosen. B, C, D. Okay, option B is a right answer. Completely, 100% is not possible. And let me use this as a context to project that in preparation. Even in preparation, 100% completion of syllabus is not practically possible because science is ever evolving. We're getting new concepts day by day. And even if you allot 10 years, you cannot complete a particular subject 100%. That's a challenge, right? So my point is always try to be comprehensive and see, it's not that we know everything. We cannot know everything, but at least we should know everything that we studied. If you have this perspective, that's it. Okay? The future is all yours. The present and future is all yours. Now let's move on to image-based. Since some of you were asking for image-based, I know you're very enthusiastic in answering these questions. Let's see how many of you are going to answer this. I blocked the name using some graphics through self-learning projects. So identify the device. So it's a very interesting device. I've seen it, I've used it. So it's a very interesting device. So identify the device. So in the meantime, let me review some literature. So irrigation is very important in endodontics. So while irrigating, we need to activate the irrigating solution to make it more effective. This activation can be done manually or through machine assisted. So manual means of irrigation. This, in fact, there are several irrigation techniques. Manual, as you guys, most of you are familiar with syringe irrigation with needles, which we see most commonly being used, brushes, and manual dynamic action. And this manual dynamic agitation can be a reciprocating, oscillating, or rotating action. Okay. And I mean, in any direction as per your convenience. And machine assisted, so manual, and then we have machine assisted. Machine assisted, we have rotary brushes, continuous irrigation during instrumentation, sonic irrigation, ultrasonic irrigation, which includes continuous ultrasonic irrigation and passive ultrasonic irrigation. And then finally, in machine assisted, we have pressure alteration devices, which is negative, based on negative pressure technique. So usually when we use a syringe, we apply pressure, that's positive pressure, but it's a negative pressure technique, right? So via negative pressure technique, we have this endovac. And then we also have a rinse endo. So these are pressure alteration devices. Consider them very, very important. And yeah, it's definitely not an endomotor. No, it's not an endomotor. These are not rotary files. Yeah, one of you is very smart. Deepanjan says it's an irrigation activator. Okay, it's not ultrasonics. It's cordless. You can clearly see it's cordless, right? And also you have 3 tip designs: small, medium, large. Okay, I've given you enough hints. So this is, yeah, I didn't give you options. Oh, I should have given you options, right? In fact, I forgot to give you options, but anyways, that's fine. Sonic irrigation. So it's an endoactivator. So this technique involves the sonic. This endoactivator is based on sonic irrigation, which is a technique involves sonic waves operating at a frequency of 1 to 6,000 hertz, which help in irrigant activation. Example, endoactivator, as you can see. So it consists of portable handpiece, a cordless handpiece with 3 different sizes of polymer tips. These are not metal-based tips, these are polymer tips, so that there is no smear layer formation. In fact, we had this discussion as well regarding the surfaces and their ability to cause a smear layer formation. So these are different sizes of polymer tips operating at 10,000 cycles per minute, right? 10,000 cycles per minute. And then you have small tips, medium tips, and large tips. It's available in their website, or you can just make a note. Small tip, the color is yellow, the one which you can see at the bottom. Medium is red, the one which is attached to the handpiece, and large is blue. Okay. So small, I said it's yellow, the size is 15 size, and it has a taper of 2%. Medium, the size is, that is the red one, the size is 25 with a taper of 4%. And large, it is blue, size is 35, and the taper is 4%. Please memorize them. I wanted to memorize them, yes. Okay, I'm really glad you guys tried, but don't worry even if you're wrong. Endo activator. Right? Now, let's move on to a final aspect of this presentation, case paste, which is, I'm sure, your favorite. So while cleaning and shaping the canal, and before we proceed with this, please don't answer this question. We'll start our next quick revision class with this case-based question. So consider this as your homework, okay? While cleaning and shaping the canal, an instrument separates in the canal. As you attempt to retrieve it, the broken instrument passes partially through the apex, thus partly protruding into the periapical lesion. How do you manage this case? Option A, use a smaller H file to bypass it and try retrieving it, H file. Option B, use GG, Gates Glidden drills, to widen the canal and try retrieving it. Option C, extract the tooth. Maybe easy for you, but what about the patient? Option D, raise the flap and remove the instrument surgically, followed by GP, filling of the canal. So go through this question once again, at least twice or thrice, and tell me the most appropriate answer and why do you think that a particular option is more appropriate. Okay, so please don't answer this question. Consider this as a homework question, and you can answer it in the next quick revision class. Okay, so as I said, we'll restrict these sessions to limited time possible, and then we'll make sure that these are more qualitative in nature than quantitative, because last time we had this experience trying to mug up so many things, trying to deliver so many things in 45 minutes or 1 hour. It's all getting crazy. So let's divide and conquer, right? I hope you enjoyed today's session, and your feedback is always welcome. Always welcome. Okay. So you have any further queries, you need any further clarification, especially related to those endoperiod lesions, you're more than welcome to get back through mail 24/7. And as I said, your feedback is almost always welcome. Not almost, always welcome, right? So I hope your prep is going on fine. Just couple more days, like not even 1 month, maybe 1 month, right? So we have very limited time, but make maximum use of it and try to give your best, and don't worry about anything else. You have nothing to worry about. This is not a matter of life and death. This is not a matter of proving something to someone. This is for your own sake. So when you're doing something for your own sake, I'm using these words very cautiously, you do it with love. You know, look at mother, look at how she takes care of her son or daughter with love. She feeds him or her with love, takes care of him or her with love. So when you're doing something for yourself, you'll do it with love. And when you do it with love, there is no such thing as stress business or panic business, right? So it might take time for you to understand, or even if you understand, it might take time for you to implement. But most importantly, always keep trying to give your best. And as I keep on reminding you, it's very important to always remind certain things. And this is one such thing, which is you cannot entertain positive and negative simultaneously. Don't say it's an electrochemical cell. This is not an electrochemical cell. So you cannot entertain both positive and negative simultaneously. I'm talking about thoughts. You can only be either happy or sad. So which thought you won't entertain is your choice 100%, right? So with these words, let me conclude this session. And it's all about working hard, working consistently, and most importantly, believing in yourself. So just believe in yourself, give your best. You have nothing to lose, you have nothing to worry about. For any further queries or assistance, you can always get back through mail at howtobedentist@gmail.com 24/7. So keep smiling. Love you all. Take care. Good night. Yeah, that's wonderful to hear. That's wonderful to hear that you enjoyed this session. Just keep this enthusiasm and momentum going. Love you guys. Love you. Take care. I'll see you again. I cannot guarantee tomorrow. Tomorrow I again have some hospital-related work, but I'll try my level best to get back and conduct this live session, quick revision class. But anyways, as I said, I'll at least let you know 6 to 8 hours prior to the session, prior the scheduled time. Okay, by 2 p.m. or 1:30 p.m. I'll confirm the class, and then you guys can have a confirmation from my side. Okay, right. Take care.